Vanakkam. I am Dr. Sheela Nagusah. Yes, I am the new kid on the block. So, unlike to that of the other speakers, I don't have much of accolades to my degrees in here. Yes, I proudly call myself as a preventive health family physician because after going through all the talks in here, now that you have come to the preventive measures rather than treatment. So here I take you along the pathway. Have been contacted by Eli Lilly for this talk, and all these slides have been sponsored by them. Okay. So today we are going to talk about something fundamentally shifting from what we have been already treating for the diabetes. We are going to something called preventive measures. We are moving beyond just GLP-1 receptor agonism, and it is a new pharmacological paradigm with dual GIP and GLP-1.
Slight change.
Yep. No, I'm just talking about the first thing. So it is mechanistically distinct molecule we are going to talk today. It is mechanistically distinct molecule that belongs in its own class. We can't tell that this is a diabetic drug. We can't say it is an anti-obesity drug. It is a class apart. And the evidence strongly supports that. So the title of this season is Deliberate. What we say beyond GLP-1 receptor analogs, we are not being hyperbolic in here, but we are being scientifically precise. Tirzepatide is a synthetic fatty acid acylated peptide. How does it act, madam? It is looking like our incretin analogs, like the GAP and the GLP peptides in our body system. And this is a very new drug, and there is no prior approved agent has achieved this kind of analogs. And as we all see today, this dual action translates into clinically meaningful and superiority in the glycemia, in controlling the glycemia, the weight, and the composite endpoints we are going to talk today. So here we introduce Mounjaro, the first in a new class of GAP and GLP-1 receptor agonist. In 2022, approved for marketing in the United States and Europe, and here we are 2026. So has been cited by multiple consensus and guidelines, GAP and GLP receptor analogs included as a separate category. As I told you, you can't name them as an anti-diabetic drug per se. This is from the ADA guideline. At present, Mounjaro is the first and only approved single drug. In ATC classification of WHO, the Mounjaro is included in a separate category. So the meaning of X, mentioning this drug as X meaning is the new and innovative pharmacological product will therefore often be classified as X. So it is not anti-diabetic, it is not something else. Now we move on to the case studies. So here we are going to talk about like day-to-day practice. We must be always seeing many patients coming to us with diabetes and obesity, and diabetes and fatty liver, diabetes, like the doctor was telling in other slides, they come with multiple comorbidities because of, I can't say diabetes, because of the obesity per se. So as a family physician or a preventive health physician, I used to keep on writing one medicine for diabetes, one for fatty liver, one for weight reduction, one for osteoarthritis, and my prescription seems to be so huge for my patients to gulp each and every drug. Doctor, where is the space for me to have food then? So here we go. This is like a clinical case scenario where we come across in each and every day in our practice, right? Take Mr. Ajay R. He's a 52 years, I won't say old, I will say young. So 52 years young gentleman, and whose BMI is 30.7 and body weight of 92 kg. HbA1c is 9, fasting 150, postprandial 210, triglycerides 168, LDL of 128, BP 140/92. So here we go, he has a long-standing diabetes, 9 years, hypertension, dyslipidemia, mild neuropathy in both the legs, and impairment of the fine touch. So no history of hypoglycemia and pancreatitis. I'm mentioning it and stressing on that because, and he doesn't have early cataract changes and no NPDR or PDR. Again, I'm mentioning this specifically because we know that this medicine can't be used when we have this complications in our patient. So he's worried about his glycemic control and future risk of complications my other fellow physicians were talking about here, the microvascular complication, macrovascular complications, fatty liver, obstructive sleep apnea, osteoarthritis, and socioeconomic problems too, depression, anxiety, right? So currently this gentleman is on metformin, Yempa, amlodipine, telmisartan, rosuvastatin. Like how I mentioned, no, for each and everything I used to. They have not mentioned about the fatty liver treatment part here. That is also included for our patient, right? So many medications. I won't say polypharmacy, but it is what warranted, and this is what we have been writing in our practice. This is holding good. Even I also thought 1 year ago, okay, this is what I have been prescribing, and my patient is happy. His sugars are under control. But as a physician into practice for 25, 27 years, almost like many seniors, the stalwarts are here, you all must be telling, I have been treating diabetes. And we used to concentrate on this particular number called fasting, postprandial, and HbA1c, and nothing other than that. Okay, then we looked into the eyes, then we looked into the neuropathy, but anything apart from that, no. So what is happening is, even though I was concentrating on bringing this down of fasting and PP, my patients still used to come with micro and macrovascular complications, like Dr. Usha was mentioning in here. So what is the problem? Why, even after controlling these things, my patients are coming back with this? Because, as Dr. Usha was mentioning, when the patient gets diagnosed with diabetes, please try to understand, they tend to manifest the microvascular, macrovascular complications. So we should be addressing them. That is the reason this particular patient has been put on the rosuvastatin 2, 20 mg. So what would be our treatment goal for Mr. Ajay? So HbA1c less than, you want to bring it to less than 8, less than 7.5, or less than 7. And what weight loss target? So as a preventive healthcare physician, I keep on give that target for my patients, like that IPL target they give, no? So this is IPL season, so I need to say like so many runs from so many balls. So the same thing I keep target for my patients. So what is going to be your ideal HbA1c? And now I am coming to the weight. All these decades, I was talking only about fasting, PP, and HbA1c. Now, a separate column over there, I say, this needs to be a weight. Okay? Right now, I don't want to increase your pharmaceutical medicines. I would like to bring this down. So whatever medications I used to give for 2-3 medicines for the sugar, one for the BP, one for the cholesterol, one for the fatty liver, one for osteoarthritis, now I am going to bring down, shrink my prescription. Hey, hooray. So what would be your line of treatment for Mr. Ajay? Are you going to add a sulfonylurea? Are you going to add a basal insulin, GLP-1 analog, or a GAP-GLP analog, or add a TZD? 1, 2, 3, 4, 5. Anybody with me? Hello? Okay, I don't want it to be monotonous. Anybody with me? Who wants to add what for Mr. Ajay? 1, 4. 2, 3, 4. Already you had the coffee, is it? Okay. So after discussing with Mr. Ajay, you decide to shortlist him for an incretin-based therapy. The choice is to decide between existing choice of GLP analogs or adding GAP and GLP analogs. What evidence would you revisit to take decision on the same? So all this while we have been thinking, we have been rigorously telling him, you can't have carbs, you can't see rice, you can't do idlis, you can't do chutneys. Oh, sorry, it's not chutneys. And other carbohydrate food. I am a typical South Indian. I crave for rice. You can't be like 3 days, 1 week, yes. Beyond that, no. I want to have my rice, okay? So there are like how much of rigorous lifestyle changes you can tell them. On top of it, the patient is so obese and you ask them to go for the walk. The patient like, are you mad, ma'am? Are you asking me to walk? I'm having such a pain in my knees. I can't do the walking. So gone are the days you keep pushing them for low carb diet. You ask them to go for running and the marathon and the trekking. Please. Now we are living in the Gen Z area. They are asking like, can you give me something simple which can give me the magic? Okay, I can't say this is a magic wand, but you must deliberately stick on to the lifestyle changes. Then only this works. Otherwise, this doesn't work. So how does this work? ADA recommends, when choosing glucose-lowering therapies, prioritize medications with beneficial effect on the weight. So right now, they started they started coming towards the preventive health, that is my department, and they started telling, you are in the secondary level of the treatment, madam. You are giving medicines to lower the sugar. Where is prevention happening here? So the AD started telling them, you have to prioritize your medications which shall bring down the weight. Consider regimens with high to very high dual glucose lowering, and at the same time weight efficacy like tirzepatide and injection semaglutide. Hooray! So how do we differentiate between these two new drugs in the podium now? Mounjaro versus semaglutide in patients with type 2 diabetes. SURPASS-2 trial. So what does it say? SURPASS-2 trial mentioned that when you give these new drugs to our patients, it brings down the HbA1c. Yes, madam. This brings down the HbA1c. Yes, that was my prime goal. But which one should I use? So here we go. They compared the semaglutide with the Mounjaro. Semaglutide, they gave 1 mg, then compared with our 5 mg. With 5 mg of Mounjaro injection itself, it demonstrated superior HbA1c reduction compared to the semaglutide of 1 mg. Even at the 5 mg dosage, I am mentioning it again and again. So the average change in the glycated hemoglobin from baseline in 40 weeks, we saw all these things. So, okay. Again, in SURPASS-2 trial, comparing Mounjaro with the other drug, 51% of the patients achieved normoglycemia with Mounjaro 15 mg. So here when you look up, so the gray one is the semaglutide, and they looked up with the 5 mg, 10 and 15 mg of the Mounjaro. You can see that 86% of reduction in the HbA1c, they brought down to less than 7. That is my prime goal, right? Like my other speakers, esteemed speakers were talking here, we can bring the patient to pre-diabetic or make them non-diabetic too. So when you look up there, so it was able to bring down the HbA1c less than 7%, which is the average goal, target we give to our all diabetic patients, right? But when you look up furthermore, it was able to bring it down to 6.5, even less than 5.7%. Compared to the other drug, which was able to do only to 80 or 66 or 20%. So Mounjaro SURPASS-2 trial, Mounjaro demonstrated, now we are coming to the second endpoint, weight loss. The Mounjaro demonstrated greater weight loss even at 5 mg dose compared to the other drug with 1 mg. So here we look up, this was given like 468 patients had the semaglutide with 1 mg, it was only 6.2% of reduction in their weight. But when you compare this with Mounjaro of 5 mg, we were able to bring down 7.8% of reduction in the weight. When you go to 10 mg, it brings down 10%, and if it is 15%, 15 milligram is given, we are able to bring it down 12% of the weight. Why this 12% is very important? Like our esteemed speaker was telling again, madam, if you bring down only 7.8%, you are able to concentrate only on the glycemic control, which we have been doing. I have been doing all the while. 25 years, I have been writing only diabetic medicines. I am not going to prevent the complications. But Dr. Usha was mentioning with the other trials, if you bring down the weight by around 12%, you can prevent the cardiorenal complications. So here we started looking up something entirely different. Rather than bombarding your patient 1 tablet or 2, 3 or 4 tablets for diabetes or insulin, and we are adding on osteoarthritis medications, we are adding on fatty liver medications, we had cholesterol medication, aspirin medication, blah blah, and then this wonder drug says you can bring down your weight, the weight of the patient 12%, plus you can bring down the cardiorenal complications happening to our patients. So again, Dr. Usha was mentioning, she mentioned when she walked in here something, it is like, it is not only the control of the weight, the longevity. So somebody started mentioning that, why our patients are dying, why our diabetic patients are dying? They are dying because of, mostly in India, all the states I would say, they are dying because of the cardiorenal complications. Plus infections too. Okay, so because I am an infectious disease specialist, I need to tell that too. But the most common cause for the death in our patient is, the morbidity in our patient is the cardiorenal complications. And this drug, they say, it is able to prevent that too. So 3 times the patients achieved the composite endpoint. What is the composite endpoint, doctor? So gone are the days I keep on telling the target only HbA1c should be less than 6.5. I started telling, hello, you must reduce at least more than 10% of the weight and without clinically significant severe hypoglycemia. Mind, we dread hypoglycemia in our patients. One single episode of hypoglycemia, the patient says, I can't touch insulin, doctor. And this drug is able to achieve all these composite endpoints. It is able to reduce your HbA1c by to less than 6.5. It is able to bring down the weight more than 10% in our patient without clinically significant severe hypoglycemia. Compared to the other drug, if you see, it was 22% with 1 mg. But in our patients, we didn't see much of these things. What is the main side effects you used to see in our patients with this Mounjaro? Okay, you convinced me now to write the medicine. But what are the side effects the patients will be showing up, doctor? In other podiums where I spoke, I saw my fellow physicians telling that they give this medicine, that medicine to prevent the nausea and vomiting. But the nausea, vomiting, other gastrointestinal side effects which I saw in Mounjaro is very pretty less. So yes, Mr. Ajay gets it. His HbA1c came down by around 2.5%. We are able to normoglycemia in half of the patients. And superior weight reduction by 13.1% with Mounjaro. So now I move on to class 2. You ask me, doctor, is this medicine only for the patients who are with diabetes and obesity? No. Now I am going to paradigm shift where I would like to prevent the patient with diabetes moving on to the with obesity moving on to the diabetes. So meet Miss Aveena. She's BMI is 35.5 with a body weight of 88 kg, LDL of 130. She's on rosuvastatin. She's not a diabetic yet, but there is a family history of diabetes. Mind, because if a person has a family history of diabetes, their children tend to be like this. So what would be the treatment of approach for Ms. Veena? Advise her a very low calorie diet and aim for the 5% weight loss in next 6 months, or advise her a 500 kilocalorie restriction from baseline and a target for 10% weight loss in next 6 months, or start her on pharmacotherapy in addition to the lifestyle measures, or refer her for bariatric surgery. 1, 2, 3, 4. Anybody with me? Time for coffee, is it? Who wants to give what? 1, 2, 3. Okay, so addressing obesity may improve or prevent significant detrimental effects. This is the same slide as my doctor was showing in here. It can bring down the hypertension, cholesterol, and cardiovascular outcomes. It can prevent diabetes. It can it can cause remission of the diabetes. It can prevent osteoarthritis, sleep apnea, GERD, NASH, MASH, and PCOS. One of the doctor was asking in here about the PCOS. Yes, it is going to come very soon now. So weight loss as early as 4 weeks and significant weight loss up to 22.5% at week of 72. Many of my patients start showing the weight loss, I would say not at the 2.5 mg, the dose we start with on the first month, but with the 5 mg, the next 2-3 months, I see them having drastic weight loss, say up to 10 or 12 kgs. I don't exaggerate much because I always tell them it is up to how you react, how the genes react to the medicine, and what is the family history. With the family history, the amount of the weight gain or weight reduction in our patient little bit changes. So Mounjaro maximum therapeutic dose versus semaglutide maximum therapeutic dose in patients with the obesity is SURMOUNT-5 trial. And this trial, they mentioned that Mounjaro MTD demonstrated 40% superior mean body weight reduction versus semaglutide MTD. Okay, so if you see, it was like only 15.4% versus 21.6% of weight loss with Mounjaro. Significantly higher participants achieved weight loss goals on Mounjaro MTD versus semaglutide. Here you can see the semaglutide, only 67% of the patients achieved the weight loss. With Mounjaro, it was 86.7%. And with semaglutide, it was 46 in here when you compare with the 71.2 with our Mounjaro. And here goes with the other slides. So body weight reduction targets like 36.2% achieved 25% of the weight loss on the Mounjaro MTD on 10 or 15 mg. And 54.8 achieved 20% of the weight loss on Mounjaro MTD on 10 or 15 mg of the dosage. So Mounjaro MTD demonstrated 36% superior waist circumference. Yes, the waist circumference becomes the goal marker for the cardiovascular complications. And in our patient, the waist circumference reduction was 7.8 inches. Can you believe it? So 7.8 inches of weight circumference reduction on Mounjaro MTD at 72 weeks with 10 or 15 mg of the dose. So Mounjaro has consistent and well-established safety profile compared to the other drugs. So Ms. Veena, she has become slim and fit now, Mounjaro, and fit like a fiddler. Mounjaro can help patients like Veena achieve 21.6% weight reduction, mean weight reduction of 22.5%, and weight reduction of 8 inches with this beauty drug. So Mounjaro is the first and only approved GIP and GLP analog for type 2 diabetes and obesity. ADA classifies them as a separate novel class of drug. In people with type 2 diabetes, participants on Mounjaro experience HbA1c reduction up to 2.5, normoglycemia in 51% of the participants, 2 times the weight loss versus semaglutide 1 mg. In people with obesity, participants on Mounjaro experience weight loss of 22.5 and waist circumference reduction of 7.8 and superior weight reduction versus semaglutide maximum therapeutic dose. Thank you so much.